Welcome to SBIRT Training, Screening, Brief Intervention, and Referral to Treatment. And we're going to cover both youth and adult populations today. Our agenda: why we do it, evidence-based screening, brief intervention discussions, referral to treatment-based practices, and SBIRT implementation. Substance abuse, as we know, there's a lot of opinions on substance abuse. It can be a misunderstood disorder, and this can be misunderstood both by providers and those who use and abuse substances. So there's, all sorts of opinions. Substance abuse is a sign of weakness. There's nothing you can do about it. Some people have a misunderstanding of how dangerous certain substances can be, especially if they're legal substances. Many who use believe that there's no hope and nothing else is going to work and nobody can help them. So while we're doing this, we do want to kind of look at our own biases and some of the things that may come up for us with substance abuse so that we can start to address some of those. The problem is it can be hard, right, to understand why people use substances. And the bottom line is people use substances because it works. Substances fulfill a need. Drugs are really kind of the great equalizer, right? So you can not use them to feel worse. You can use them to feel good, to have new experiences, and to have these experiences shared with others. We know that many people report substances help lessen a myriad of negative emotions: anxiety, worry, fear, depression. And of course, if you're already using, it's going to help with your withdrawal symptoms. Trauma is a huge risk factor. Adverse childhood experiences can be a significant risk factor. We know that ACE studies have shown how common ACEs are in our population. We know how common it is for people to have experienced these adverse childhood experiences. But we also know how substance abuse itself increases someone's risk of experiencing trauma. So these are lifestyle factors, high-risk choices, high-risk peer groups. All of these contribute to more trauma. And if anybody has ever taken an ACEs training, which Western Tidewater also offers, the numbers that this impacts throughout the country are usually much more significant than a lot of people understand. Here are some recent statistics from SAMHSA 2023. I looked at this statistic recently and I was like, oh my gosh. So they did a national survey on drug use and health. Half of the population drank alcohol. Binge alcohol use, you can see these numbers, right? Underage binge alcohol use, heavy alcohol use, underage use. So this is a significant portion of the population who is experiencing at least some experience with some of these substances. 1 in 4 used illicit drugs. So illicit drugs were including cocaine, heroin, hallucinogens, inhalants, methamphetamines. And of course, we have this misuse of prescription drugs. 18 or older, whether they thought they had a problem with their use of drugs and alcohol, 30.5 million said yes. So when we look at the why of SBIRT, here are the numbers that we're looking at. Here are the people that we are usually seeing in our agencies. What are the trends in youth? Almost half of 12th graders report alcohol use in the past year. A quarter of nicotine. 29% cannabis, and illicit drugs, 7.4% of 12th graders. We know the impact of substance abuse. So if we look at youth, obviously, the impact of substance abuse is going to be that it impedes brain development. That prefrontal cortex is not going to be developing and doing what we need it to do. We also know the younger that a person is when they start using, the more likely they are to have a substance use disorder. Impact of substance abuse on adults, right? Financial stress, increase in health concerns, depression, anxiety, mental health concerns, criminal, all the way up until death. So we know that there are significant numbers. We know that it significantly impacts our population. We know it impacts definitely the population that comes to us for services. But interestingly, from a public health perspective, for a long time, our response to people using substances would just wait and see until we get high-risk people who already have a substance use disorder, and then we were very reactive. Then we would offer treatment, we would offer counseling, we would offer rehab, we would offer, all sorts of services. Public health agencies got together and said, what if we did this from the front end and not the back end? What if we started screening people in the beginning before it became an issue that we had to react to? What this does is reduce healthcare costs, improves public health outcomes. And the good thing about SBIRT is you can use it anywhere. So you can use it in the emergency room. You can use it in mental health agencies. You can use it in schools and healthcare agencies. And the point was, if we do regular screenings to identify substance use early, kind of serves to reason, right? It prevents more serious problems. What we really want to do is help people access evidence-based care quickly. And the good thing about SBIRT is this can be used for anybody across the continuum. This can be used for people who don't have a substance use disorder at all the way up to people who have a significant substance abuse history. So it's a pretty versatile tool to be able to use. So what is SBIRT specifically? Evidence-based approach to the early intervention. So the screening part is so that we can quickly assess the risk of substance use and then know kind of what our next steps are. And we'll go over all the next steps. A brief intervention. Brief intervention uses a lot of motivational interviewing. We're trying to focus on changing their behavior, but really we want to try to help our clients and people who come to see us increase the insight and awareness, and then referral to treatment. A lot of people who have concerns do not know where to go. Many of us are in public agencies. We go out in the community, and a lot of people just don't know what's out there. They don't know what's available. They don't know what services. They don't even know who to begin. So the SBIRT, when introduced to all public health agencies, starts to educate the community on where you can go when you do need help. So screening in general is a systematic way of identifying potential problems. It identifies people who may be, but here are the two main words to look at. It's standardized, reliable, and valid. Standardized is the big tool because we know substance use, like I said, is on a continuum, right? So you have people obviously on the left, this is not a problem, no intervention, all the way to, yes, there's a problem, we need treatment, and the goal needs to be abstinence. So for everyone that we see, someone is going to fall, everyone actually is going to fall somewhere in this continuum. We're not necessarily going to know right away where they fall. So we don't want to assume things about the client and what kinds of high-risk behavior they may be having just because of how they present. SBIRT can be used with everybody on the continuum regardless of how they present, which is why having systematic, standardized screening for everybody in all agencies is the way to go. You can be like Oprah. You get a screen and you get a screen, right? The best way to approach SBIRT is to do exactly what these posters say. We ask everyone. We want to know from everyone. If you don't have any concerns or don't use substances, great. You say no on all of the questions. If you do have some concerns with substances, this is a built-in way to do it. But to avoid us falling into the trap of deciding who should get a screen and who shouldn't get a screen, the best way to do it is make it a systematic thing across the board where everybody gets a screen. You build it into your intake process. You build it into your assessment process. You build it into that initial paperwork so that you are not left trying to make the choice and decision of whether or not this person presents as though they may need help. We just assume everybody gets a screen. Therefore, we're going to not have to make those decisions. So universal screening reduces bias. We no longer have to be the ones trying to decide whether or not this person falls within the norms of what we need to be screening for. It is something that we could give to them, but it's also best done self-administered in a private setting. There's all sorts of screening tools that we're going to go over that you can combine, but it also helps us because a lot of people, when it comes to substance abuse, may not have really looked at their own biases, and we need to kind of assess our own comfort level for addressing some of these topics. If you establish a screening process early on, everybody expects to have it. And then of course, within your agency, it's going to require, you know, the timeline and everything for you to decide how you're going to streamline that. Here are some screening tools that are very typical. Some of you probably have used these in some of your agencies. I used to work for the court system. We used the SASE. We used the CRAFT a lot, the audit, the DAST, the S2B1. So there's all sorts of names for all of these, and all of these are online. You can Google all of them, but I'm going to go over a couple of them that can be really helpful to use. So this is the S2B1 for adolescents. And as you can see, it is simple. The idea of screening is to very quickly, easily, and simply for you and them determine whether or not you need to go to the next step. Super simple. Never, once or twice, monthly, weekly, or more. If you say no to all of these, that's it. You're done. Turn it in. Everything is fine. Otherwise, you can continue with some of the other questions. But again, the screening of the SBIRT is not meant to be super complicated. It's a very, simple questionnaire, and this will give you some quick answers. Why this specific one? And some of you may use the specific one. The American Academy of Pediatrics has actually endorsed this, and it does correlate to the DSM-5 diagnosis. And like I said, these are all free. They're online. All of these screening tools are available. You can download and print them off. They are very quick. They're very practical. And if you go to different websites, they're available in a variety of languages. So these are very, very simple tools to use that are easily accessible to anybody, free to you, very simple for your clients to fill out. Okay, the scoring for it is also very simple. So if there is somebody at a risk for substance abuse, you're going to put them into one of 4 categories. And we're going to go over with each of these categories later on. If somebody falls into a category, well, what do you do next and what do you say? A prevention opportunity is obviously for those who have no use at all, who aren't thinking about using. Low risk, they've used once or twice. A moderate risk is considered somebody who has a monthly use, and a high risk is somebody who uses weekly. So when you have a screening tool, there is going to be a scoring tool right after it so that you can very easily determine what level of risk your client falls into. Another one that's used often is called the CRAFT. And the CRAFT, again, starts off very simple. You, in the past 12 months, look at whether or not you've had a few sips of beer, used any marijuana, used anything to get high. Again, if the answers are no, it even tells you right there in the screen, stop. Don't go any farther. If you've put a 1 or more in any of these boxes, then you answer questions 4 through 9. So the CRAFT stands for car. Have you ever ridden in a car? Relax. Have you ever done anything to relax? Alone. Do you ever use drugs or alcohol alone? The F is forget things while you're using drugs and alcohol. And the second F is friends or family. Have they ever told you should cut down? And then you have the T. Have you gotten into trouble? So it's a quick, easy screen. Again, this can be used for children and adolescents. We want to remind them this is only for the past year. So when you have a 16, 17, 18-year-old or even other children, it's a lot easier for them to remember recently than it is for them to try to figure out what's gone on their entire adolescence. Here's the screening for the CRAFT. If you have no use, obviously, in the past 12 months, you're a risk level of low, score of 0. Medium, no use in the past 12 months, but you have a yes to the CAR questions, or use in the past month, and your score is greater than 2. A high risk level, your score is greater than equal to 2. Use in the past month. So again, these are very simple, quick screening tools with very simple, quick scoring ability for you to be able to determine what you should do next with your client. So here's some things to consider about, though, when you're doing screenings with youth. The parents may not want you to do it, right? They may be conflicted. They may be concerned about who is going to get this information. They may not want people to know. They may be aware of the concern and not think it's a big deal. So it's really important to develop a standardized process, again, especially when it comes to children and adolescents, so that parents know this is going to be something that is going to be done. We're going to promote this well before the teen years. So if you're dealing with a pediatrician's office, if you're dealing with a school situation, this is already going to be built in. So it's not going to be a surprise. We're not signaling, that's not the right word. We're not being specific to your kid. This is what everybody else gets. We want to make sure that we reassure them of the privacy laws. We want to make sure we reassure them that they are a minor who gets the information. And we want to make sure that, we are emphasizing confidentiality and what's going on with that. How can you do that? When you're talking about screening youth, here are some ways that you can give this message to the parents and the kids. So our goal is to have a trusted relationship with you both. Accurate information is shared, but across the board, obviously, the end goal is going to be that we give the best care possible. To the parent and caregiver, we want to reassure them. If there's a serious health issue or there's an issue with safety, we're going to bring you in. We're going to let you know. We're not going to keep you in the dark. But again, the message needs to be, starting at whatever age it is your practice decides, young people are going to be seen at least a portion of the time without their parents, because you want them also to start having ownership of their own health. How do you talk to a kid? I'm concerned about any serious health problems or issues for safety. I'll let you know if I'm feeling the need to bring in your parent. So these are some ideas of how you could overcome some of those concerns that parents and children may have when you're doing screening tools. For adults, this is an example of the Audit C. It's a little bit more than the adolescent version. But again, these are quick, simple screening questions. How often did you have a drink? People can choose between never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 or more times a week. How many drinks containing alcohol? How often did you have 5 or more drinks? How often have you used marijuana? How often have you used illegal substances? So this is an example of an audit. Again, if you've already introduced this as a concept into your department and your agency, and everybody's expecting to do this, one of the biggest things that this expresses to people is we are very non-judgmental. We are not picking you out of the crowd to give you this screen for any other reason than you are a client here, you are a patient here, and everybody gets these. People are more apt to answer honestly if they don't believe they're being judged by things. What is the scoring like for an audit? For men, 4 to 6 for alcohol. For women, 3 to 6. Marijuana, these are the scores. 0 to 1 is negative, positive and high positive. Any other drug scoring for the audit, 0 is negative. Anything greater than 0 is positive. So it gives you an idea, again, 3 different categories. That's it. This is not this super complicated scoring process so that you're spending hours and hours trying to figure out where they would fall once you have the screen. Okay. The audit self-report version, and again, a lot of this can be easily done by giving them the screen themselves, is to simply say to them, because alcohol use can affect your health and can interfere with certain medications and treatments, it's important we ask some questions about your use of alcohol. Your answers will remain confidential, so please be honest. So we have 3 things there. Everybody gets this. Please be honest. We're not telling anybody unless there is something that, is outside the realms of our informed consent and confidentiality. So the self-report audit is the same thing. How often do you drink? How many drinks containing alcohol? How often do you have 6 or more drinks? How often during the last year? And how often have you failed to do what was normally expected of you because of drinking? So as you can see, a lot of this does line up with this DSM diagnosis as well, but they're not going to necessarily know that. We just want to know exactly what this first sentence says. We know as providers, alcohol can affect your health. Also, if you are having medication, it can interfere. We just need to kind of know what's going on so we can best provide you with services. We're not judging. We're not saying there's a problem with you. We're just screening you to determine what services might be best later. We're not mandating you go to services unless there's a court thing. We just want to make a recommendation for the services. Here's the rest of the audit. It's the same thing. This message is at the top, and then the same 10 questions. Again, 10 questions for adults, 5 questions for children. It is a very, very simple screening tool. So once you have introduced the screening tool to everybody, given the screening tool to everybody, ensured confidentiality that we're going to be non-judgmental, and we would ask that they be things. So what do you do with the information? You have it, you score it. Now we get to the brief intervention part. So as you can see, for the SBIRT, this is not time consuming. These are very, very quick, simple tools that we can use. So what is a brief intervention? Literally, it's in the name. It is brief. 5 to 30 minutes, maybe. The goal of a brief intervention conversation is to motivate them to change their risky substance use behaviors. That's it. That's what this is. This can be 1 to 4 sessions, but really we just want to say, hey, let me give you some information. There's some risk associated. Is there any internal motivation? And what kinds of things and goals can we help you work towards? This is done with motivational interviewing, which I'm sure many of you are familiar with. But the idea with motivational interviewing is it is a specific way to talk to people about change, about growth. We're not forcing anything on them. We're trying to strengthen their own motivation and commitment. Motivational interviewing has certain things that they focus on. The biggest one is expressing empathy, making sure that we are not providing judgment, because there is a lot of judgment that comes with substance use. People are used to being judged when they talk about their drug and alcohol use. We want to develop discrepancy, meaning we want to help them realize that yes, they want to do it, but they also would like some other things too. And there's going to be these pros and cons and push-pull that everybody has when thinking about making a change. We want to roll with resistance, meaning you're not going to argue anybody into changing. You're going to not force them. You're not going to demand anybody do anything, but there's going to be some understandable pushback. Again, people are using substances because they're meeting some need, and you're now proposing that they not use substances. The natural inclination is, well, hold on, time out. If I can't use these substances, how is my need going to get met? Because again, a lot of people simply don't know what services are available. And of course, we want to support self-efficacy. Everybody has within them the ability to be able to do this, but a lot of people simply don't have the tools or knowledge to be able to do it. Understand with motivational interviewing, wanting something and not wanting something simultaneously is completely normal. We go through this probably on a daily basis. You know, I want to eat healthy, but the French fries look good, right? So everybody has ambivalence for a lot of decisions we make, and it is completely normal. We also know human nature results in, if we push too hard, people are going to resist it. We know this is also very true for adolescents. If you say left, they say right. How do we then evoke their own change talk so that they will be able to enhance their own change? And it's not going to be because we force feed them information and tell them they have to do this. It is, let's look at what's working for you with this. Let's look at what's not working for you. We're not going to judge you for it. We're going to give you some tools if you choose to move forward with some decisions. Okay, so the brief intervention model is based on this acronym FRAMES. So FRAMES is feedback, responsibility, advice, giving them a menu of options, empathy, and self-efficacy. So we're going to go back to this. So what does all of that mean? When the screening tool has been done and it is brought to you when it is time to begin the brief intervention part, we need to begin having a conversation, a personalized, relevant conversation that is age appropriate, specifically to whatever it is that their score has said. Because a lot of people coming to you can be completely unaware that what they are doing and the level that they are doing it at can be harmful to their health, especially if you have somebody in the teens and early 20s and it is contextually something that their peers are doing. So we have late teens, early 20s college students, for example. Everybody is drinking an extraordinary amount. And a lot of people confuse what other people are doing, if there's a lot of people doing it, with a lack of safety, which we know is not true. How would you do this? How would you begin to proceed? So here's an example. Factually, you scored a 16 on the audit, which indicates you're at a high risk of harm from your current pattern of drinking. We're not judging. We're not assuming anything about their lifestyle. We are simply giving them the score and telling them what this score indicates. We want to help them recognize at that point that they are then responsible for our own behavior. We cannot, again, make them change. We're not responsible for making those changes, but with that responsibility comes the ability to retain control over what happens. We also want to emphasize that they have the responsibility to create the willingness to reduce or stop. And that's going to be related to how important they believe the change is, right? If they don't think this is important, they're not going to be committed to it. But also, how confident are they that they can do this? If you have people who have been using substances for a significant period of time, or people who have been using substances and have tried to quit numerous times, their confidence level might be in the toilet. They'll look at you and say, yeah, I hear you, but I can't do it. I don't know how to do it. I don't have the tools to do it. I've tried it before and I failed. I cannot do that. So with these conversations, with these brief interventions and motivational interviewing, that's something that we need to kind of pick up on and respond to. So responsibility. Check in. Are you interested in seeing how you scored? What do you want to do with the information? How concerned are you about this score? It's not our responsibility. It's not our concern that we are looking at. If we tell you you score very, very high, indicating that you are at high risk with your current pattern, does it bug you? Does it bother you? Some people be like, whatever, I'm cool with that. It may bother them, it may not bother them, but we need to check in so that we're emphasizing they're taking responsibility. We're going to give clear, I can't say non-judgmental enough, right? Non-judgmental advice. Insight into the benefits of stopping, because again, what is our point? Our point is not to mandate they do something. Our point is not to say, oh my God, if you keep this up, you'll be dead by Tuesday. This is not our point. We want to increase awareness and help them understand the benefits of change. Again, some people have no idea what the first step is. So we look at it and we're saying, of course, the first step is to reduce. Again, a lot of people may not have that kind of linear thinking. So we can say it. The best way you can reduce your risk is to cut down or stop completely. I mean, that seems like a no-brainer from our perspective, but we have people who come in who may never have thought that or been told that or been, told that by people. Again, risky or hazardous drinking is associated with fatal motor vehicle crashes. We think, of course it is, but sometimes you have to say it out loud for people to hear it. Menu of options, offering a range of options. We want people to, again, feel as though I can take responsibility for my change. There are choices for me. Reinforces personal control and responsibility. How do we do that? Let's look at what's going on in your life. Let's look at what kinds of choices you have at this point. What do we do now? Identifying high-risk situations and strategies, right? And we do this a lot with treatment too. Identifying substitute activities instead of substance use. Encouraging the client to identify people who could provide support. Setting aside money they'd normally spend on substances. So again, if you are in any sort of treatment, if you do any substance abuse treatment, you develop treatment plans, a lot of these things are things that may come up when you're developing an ISP. But these are things that if somebody comes in and they score a high number on a screening tool, they may not have thought of. They may not know what the next step is. They may not have any idea what to do. And they may not want to go into treatment. They may not want to seek counseling beyond your door. They may not want to be referred to anything. So we want to have some choices available so that they themselves, even if we never see them again, or, they decided nothing else. Here are some things you could do today if you're interested in changing. Quick, easy things. We have a list so that they have choices. They may look at you and say, yeah, whatever, but at least they do have this menu of options that they could choose from later if they chose to do so. Empathy. Empathy is not sympathy. We're not feeling bad for them. We're not patting them on the head and oh, we feel so bad for you. We want to demonstrate understanding and support. It may be difficult, but understanding the client's point of view, understanding that they are using these substances for a reason. This is meeting some sort of need. They are doing this because it works for them in some way. We want to avoid the use of labels and basic reflective listening. Reflect back to them what they're saying. I know this can be confusing. I'm sorry to see you're in this situation. I'd like to help. Let's see if we can solve this together, right? So we're just going to kind of, hey, I understand. We're not judging. We just want to make you aware. Here are some tools. And again, self-efficacy. We want to encourage confidence in the person's ability to change. Summarizing everything. This can be difficult. I know this can be overwhelming, we have some tools here. We'd like to be able to give you some information. Is that okay? Shockingly, a lot of people aren't going to be happy with this idea, right? There are going to be people who come in who are not ready to change at all, or who don't trust you, or who have very much committed to this lifestyle, who have no other options in their head, which, you know, what they can do. They don't think that you're going to keep this information confidential, and so you're going to have resistance. The deal with resistance is we need to understand that everybody is going to come in at a different level of readiness to change. So what works best with each stage of change? So in motivational interviewing, there are 5 stages of change. And here's what works best with each one. So you're going to have some people who are in pre-contemplation. So in pre-contemplation, these are people who are completely unaware their behavior is a problem. It's fine, no big deal. Everybody does it. I don't want to change. They have no worries. They have no desire to change. So when you have a client who's responding to you, who may or may not have scored high on a screening tour, what can we do? Give information. That's what we're doing. They're not ready to change. They're not ready to go off into maybe some other treatment things, but we have an opportunity to give them information about the risk associated with use. So that's what we want to do. Give them information so that they can take that responsibility, learn to recognize risk, and maybe at that point, consider change. We're just increasing awareness. Maybe putting some interest in their head, maybe some concern, but at that point, they have already said to you, thanks, but no thanks. Okay, here's some information. We want you to know that you're at risk for X, Y, and Z. You can certainly return to us if you need to. The next stage is called contemplation. So these are people who may say, you know, yeah, I've been thinking about it. I might have a problem, but I don't really want to stop. They start to see the problem, but they're ambiguous, right? They want to change, but they don't know how. They don't know where to start. They don't know who to talk to. So we want to really lean in at that point to discussing those risks and rewards. What's working for you with this behavior? What's not working for you? And when you have this behavior, how is it impacting your personal values and your reasons for use? How do we do this? We work with the ambivalence. Again, as I said, ambivalence is completely normal. Everybody has ambivalence, especially if it's a change that you aren't really committed to making. So what can you say? Hey, let's have a brief chat. What are some of the good things? What's working for you with these choices? What are some of the not good things about it? What's not working for you? So you really want to kind of do a cost-benefit analysis. So what are the benefits and costs of staying the same? What are the benefits and costs of change? Again, we're not pushing any agenda. We're not saying, aha, I caught you, now you have to go change. We're just saying, hey, I get it. Ambivalence is normal. You want it, but you don't want it. You're thinking about it, but you're not sure. Let's have a chat about that. Let's have a brief discussion about this. Again, these are very quick, easy conversations. It's not meant to be a 3-hour session. 5-10 minutes of, hey, why do you like to use? Okay, great. Why do you not like to use? Okay, great. Preparation. So you do have people who come in who are like, yep, thank God, I'm ready. I'm so happy that somebody has called me out on this. They may not use those words, but these are people who intend to take action in their immediate future. They may even at that point be willing to take some small steps. So at that point, if you have somebody who says, yes, I understand, I've really been making, I'm ready to make some changes, I've been thinking about this. Let's do some scaling, right? Explore their commitment, making a plan. Everybody uses scaling questions, I'm sure, in some realm, but this is what in motivational interviewing they call readiness rulers. So on a scale of 1 to 10, how important is it? On a scale of 1 to 10, how confident are you? And you can certainly do this with contemplation as well, but really we want to kind of explore with them. Okay, you say you're ready. How ready are you? How confident are you? Because that's going to give you an idea of really how much you can push into the next realm of this. If they say 5, 6, 7, oh, great, wonderful. Why not a 1 or a 2? You can spend some time doing that. What would it take to get it to a 9 or a 10? Action. There are people who are ready and they are taking action, right? So a lot of these people, they've already made the choice that their substance use needs to change. and they've probably already taken some steps. So if they come in and they say, yes, I understand, but oh my gosh, 6 months ago, you should have seen me then. I have already done these things. These are the steps I've taken. I still have cause for concern. I still need to take action, but I'm working on it. So these are the people that you really want to provide the encouragement and the support to implement their decisions. Strategies to identify situations in which they may be at risk. We've talked about those questions a few slides ago, and we want to discuss solutions for how to handle situations that may still be coming up for them. And then you have people at the very end who may be screened out, or who may already have gone through some sort of treatment program, who are in what's called maintenance. And when they're in maintenance, this is when they're sustaining the planned action. They've made the changes, they're sustaining the changes, and now they're working on relapse prevention. They're coming up with a plan. They probably already have a plan. They're working through, how do I avoid relapse? They need confirmation. They're doing a good job. Look at you. This is amazing, all this work that you have done. What does that do? Strengthens the resolve to persist with this behavior. So they can be assisted, again, to avoid circumstances, and this is probably built into their relapse plan, where they are at a possibility of relapse. We want to identify triggers. We want to identify warning signs. We want to identify those risky people, places, and things where they may or may not be triggered to use. Help them progress forward. This can be especially useful if they have come in and just recently lapsed. What have you done? What was your treatment plan? How do we get you back on track? Motivational interviewing has a lot of strategies that work with resistance. So one of the simplest ones is reflection. So a simple reflection is exactly what you'd think it would be. They say words, you reflect back to them exactly what they just said. Biggest bonus there, hey, this person's listening. This person pays attention. This person getting it. You didn't say anything miraculous, but they heard their own words, which means they believe that you are listening to them and understanding. Reflection with amplification is another tool. So what this does is exaggerates or amplifies what the client is saying to the point where they're likely to contradict it. So if you have somebody coming in, they've scored really high on a screening score, but they're like, I don't have a drug problem, right? I don't know, this is just doesn't make any sense, right? Say it back. As far as you can see, you haven't had any problems or harm because of your drug use. Probably not in that tone. That was a bit of a judgy tone. Now, a lot of times, clients necessarily aren't going to be like, yep, you're right, no problems, no harm, I'm good, I'm fine. This may be something that you could say where they would be likely to contradict it, and then you kind of have an in terms of that ambiguousness. You want to continue to use drugs, but you have had some of these problems and there has been some harm caused by it, and that is concerning to you. There's another tool called a double-sided reflection. You're not quite sure, you're ready to make a change, but you're quite aware your drug use has caused concerns in your relationships. They've probably said this, affected your work, your doctor's worried about your health. So eventually we want to elicit some of these concerns and that ambiguousness so that we can say exactly out loud what's going through their head. I don't know that I want to change. I don't know that I can change, but I recognize there are some reasons here where change might be a good idea. There's another tool called shifting focus. Again, we see this a lot with adolescents and young adults, but it doesn't necessarily have to be where they said, of course I can't quit. Everyone uses it, right? It's that whole, but everybody's doing it. All my friends use drugs. What am I going to do? I want to have a social circle. It must be normal. It must be fine. They don't have any problems. Everything is good. What could you say? Slow them down, right? Slow them down. Oh, no. You're getting way ahead, right? I'm not talking about quitting. I don't think you should get stuck on that. Let's stay with what we're doing right now. Just go through your feedback and we can worry about later. If you come up with anything that you want to do about it, we can talk about it later. So we don't want clients to immediately get defensive and say, oh, no, time out. This screen is wrong. I have absolutely no concern. No, you're fine. Let's not talk about that right now. Let's just continue to process what's going on. Avoid arguing. And this kind of is a human nature thing as well, but few people have ever changed because somebody came in and said, just stop, just don't. What is wrong with you? Just avoid arguing. Because as soon as you argue against substance use, they're going to give you 13 reasons why substance use is a great plan. So we want to avoid arguing. We want to ask open-ended questions. Again, questions without a yes or no answer. Here's some examples. What concerns you most? Not, are you concerned? Because it's a quick, easy no. But what concerns you most? Assuming that there would be something that they're concerned about. Suppose you continue on as you have been without changing. What do you imagine are the worst things that could happen? There's no way you can answer yes or no to that question. How much do you know about some of the things that can happen if you drink during pregnancy? Even if you don't think this is going to happen to you. So asking those open-ended questions opens the door literally for them to give you some more details into what's going on. When you just ask yes or no questions, you're not going to get anything about what really they're thinking. And affirming. What is affirming? Thanks. Thanks for coming in. Thanks for listening. You are making good choices. I appreciate you're willing to talk to me about your substance use. Pointing out some strengths. You're obviously a resourceful person. You've coped with all these difficulties, right? So we want to affirm that them engaging in this conversation, being willing to consider some change, even, coming to us in the first place. Hey, I appreciate you're willing to come and do this. Obviously, you're resourceful. You came in, you found us. And depending on what they've told you, my gosh, you've obviously been able to cope with all these difficulties up until this point. Okay. So what do you do when desire seems low? I was worried there at first, but I don't really think I have a big problem. My test came back fine. Motivational interviewing has what's called change talk and sustain talk. Sustain talk specifically focuses on sustaining their choices and their behavior. You feel fine. Sure, we've just summarized, but there's no change talk in there. You don't think you really have a drinking problem. Where is the change talk? Where would we be able to do any sort of changing? Versus change talk, looking at that ambivalence. You don't want to develop liver problems. That worries you. Now, he has said, oh, I was worried, but now I think I'm fine. My liver tests are okay. So he did not say, I don't want to develop liver problems, but with change talk, we're going to focus on when their desire to change seems low, how can we elicit some of those things that are going to then get them to the next part of the sentence? Well, yes, having liver problems did worry me. Then you have an opening into what kinds of resources are available. Okay, we're going to watch an example of SBIRT in motion.
Miguel is a 35-year-old patient who scheduled a telehealth visit to discuss his migraine headaches. He completed the DAST screening tool as part of the visit.
Miguel, before we end the call, I did want to go over the answers you gave me on the questionnaire about drug use. Is it okay if we go over that right now?
Yeah, it's fine.
Thanks. When I looked in your form, it looks like you use heroin weekly and you inject it. What part of your body do you normally inject in?
Mostly my left arm.
Right. Do you mind if I take a look at your arm, please?
No, that's okay. How's that?
Okay, well, I don't see any redness. Can you go ahead and touch that, Miguel, and tell me if it feels warm to you or if it hurts?
No, it was okay.
Thanks. Just so you know, when I talk to patients about drug use, my job is to be helpful. I'm not going to tell you what to do or what you should do. What I can do is share some information and be a resource. Does that make sense?
Yeah, it's fine.
Great. What else can you tell me about your heroin use?
I don't know. I use maybe a few times a week.
A couple times a week. And where do you get your syringes?
Syringes, sometimes I buy them at Walgreens. Most times I'll just get them from the needle exchange.
What one? Do you remember?
Northeast Gleason.
Okay. How often do you use new needles when you inject?
Yeah, I use new needles every time. Never sure.
Yeah, it sounds like your health is important to you.
Yeah, that's right.
And you showed up today to take care of your migraines.
Mm-hmm. Yeah.
So you wrote on here that you've experienced withdrawal symptoms when you've stopped using in the past. Is that right?
Yeah. If it's been a couple days, like go 2 days, 3 days tops before I start to feel real sick.
What does that feel like?
Ah, jeez. Yeah, I mean, it's the obvious stuff like my stomach feels sick, I get body aches, cold, hot, chills, everything hurts, everything's in extremes. My emotions are in extremes. Yeah, it sucks. I don't want to do anything. I just want to stay home and just stay in bed.
That sounds awful. What do you do when that happens?
Yeah, I mean, I start to use. I get loaded.
Okay. How else does injecting heroin impact your life?
uh, I get loaded and I can function. I can go to work and do normal things. I mean, there's been maybe just a couple times where I wasn't feeling all that well, and I was late a couple times to work, or might have overslept from the night before or whatever. But that's about it. I just want to avoid getting sick right now. It's my main priority.
Yeah, you want to stay healthy. I'm curious, what do you like about using heroin?
Uh, well, I like the way it feels. Um, I mean, when I shoot up, my anxiety goes away, my depression goes away. Uh, Things that usually make life really difficult get a lot easier.
And what about your use do you not like?
Oh, yeah. I mean, I think everybody who uses at least has some concern of overdosing on some level, right? Uh, so that's something I'm concerned about is accidentally overdosing. And yeah, I mean, I don't want to get an infection in my arm. Just the usual things. I have a hard time hitting veins sometimes, and I got to dig around a little bit, and I get worried about, hitting something that I shouldn't, or, getting infections.
Mhm. So, on one hand, using heroin feels like an escape from things you don't want to think about. On the other hand, it puts you at risk for an overdose and infections.
Yeah, that's right.
So, weighing what you like and don't like about your use, where do you want to go from here? What do you want to do differently?
I don't know.
Well, some patients who inject heroin are interested in a medication called Suboxone that reduces cravings, withdrawal symptoms without making you high. Some patients want information on how to inject drugs more safely or where to get new syringes. Other patients want to carry naloxone, which is a drug that can prevent one from overdosing.
Are you talking about Narcan? Is that the same thing?
Yes.
Yeah, I got some of that already. I got it from the needle exchange.
Where do you keep it?
At home mostly.
In case you see someone overdosing?
I mean, that's a concern, of course, right? I'm on the app just in case somebody nearby is ODing and I can get pinged. But no, mostly I just keep it in case I overdose. And I'm realizing now I have it, but I haven't told my roommate about it. So
Your housemate may be willing to give you Narcan if they see you overdosing.
yeah, that's what I'm thinking.
Anything else you want to do about your use?
I would really like a little bit of information on injecting in my arm.
Okay, I can email you some information on how to inject in a way that reduces the chance of infection. And we also have behavioral health specialists in our clinic who can go over how to reduce harm with you. I bet the syringe exchange has similar resources too.
Okay.
So it sounds like you have two goals right now. You want to tell your housemate about where you keep the Narcan in case you overdose. And you want some information on how to inject safely.
Yeah.
How confident are you to do these two things? On a scale of 1 to 10, 1 meaning not ready at all, and 10 meaning very ready. What number would you pick?
I'd probably say a 10.
Okay, you're very ready. Why do you think you picked a 10 instead of a lower number like 8?
Well, I don't want to have an overdose and I don't want to get an infection. Seems like easy things to do.
What kind of plan could you put in place to make sure you meet these goals?
Well, I can talk to my housemate tomorrow night. Pretty sure that he doesn't work tomorrow night, so I'll be around.
That's great. And how do you want to get the information on injecting?
If you could email me that right now, that'd be great.
Okay, I'd like to hear how your plan worked out for you if you're willing to come back for another appointment. I look forward to hearing about what worked for you and what was challenging, say in 4 weeks.
Yeah, it's fine. Let's do that.
Great, I'll see you then.
This is what non-judgmental looks like. Her goal was not to shame him for coming in. Her goal was not to force him to quit. Her goal was not to make him want to quit. Her goal was to use the screening tool to determine where he was in the stage of change, to match her information to his stage of change, to find out what his goals were, and to give him information that matches. So she remained very judgmental, non-judgmental, right? It was very positive. She gave him compliments. She focused on his strengths. You want to stay healthy. You came here today. You were looking for information. But she also asked some very open-ended questions. Sounds pretty awful. What do you want to do? How does heroin impact your life? So one of the things that we saw her focusing on was that ambivalence. What do you like? What do you not like? And she even said in her summary question, which is also a motivational interviewing tool, so on the one hand, heroin does this for you. On the other hand, heroin does that for you, which led her into the next question so that she would know what kind of resources to do. So what do you want to do differently? Some people who use heroin, and she gave him some choices, right? Some people use medication. Some people use safety. Some people use naloxone. She didn't send him off to a clinic. She didn't tell him she couldn't help. She didn't make any judgmental comments. She was able to summarize. Your roommate can give you medication. What else would you like to do? She commented on the fact that he wanted to do some harm reduction. She reviewed his goals. She went through the scaling questions that we saw, right? How confident are you? And when he gave a high number, again, very non-judgmental, very complimentary. It sounds like you're very ready. And the confidence scaling was not, I'm very ready to quit. It was, I'm very ready to go through the goals that I've already discussed with you. He was a 10. So she explored that. Why not an 8? Why not a 7? Why not a 1? She went over what the plans were. What plans are in place to meet your goals? And then the follow-up was, and how would you like the information? And can we follow up in a few weeks? So SBIRT is obviously very different than if somebody had come in for substance abuse counseling to meet with a CSAC. This is really to identify what they want based on the screening they have, elicit some of that change talk, understanding the changes they may want to make, or perhaps not the changes we think they need to make, but what are they willing to commit to? Do they recognize there's a concern and a problem? He carries around medication in case he overdoses. So he's very understanding of the fact that what he's choosing to do could very well lead to an overdose and has then made some steps. Option A is you're doing things that could lead to an overdose. That's a problem. Option B is you've made some good choices having this medication with you. What can we do to increase your safety? Well, I could communicate with my roommate that I do have this medication on me so that he would be able to administer it if I do overdose. You heard him say what heroin does for him. He likes heroin. He's willing to accept those risks to continue to use heroin. There are some choices that he wants to make to reduce some of the risks, but the overall goal was not to completely quit. So you can see how kind of SBIRT fits into it. And those who are clinicians in this particular training can obviously note the differences between where you might want to go with the goal if they had said, I wanted to completely abstain or I want to quit entirely. We meet clients where they are, regardless of what service we're providing. Change is only going to come if we meet them where they are and focus on the goals that they identify. Okay, when you're talking about youth, some of the talk is a little bit different. Some of the talk is going to look more like focusing on their future. So if you have middle school youth and high school youth, here are some reflective statements that you could discuss with them. So middle and high school, if we're just talking about people who don't want to use when they have future talk, don't let drug and alcohol use change or control your plans for the future. Okay, we want to talk to them about the risk of addiction. A lot of this is education and information. Drug and alcohol change goodness, drugs and alcohol change parts of your brain that impact how you think and act. The more you use them, the harder it can be to stop, even if you want to. When we're dealing with middle and high school students, a lot of it is just education. They don't know what they don't know. They do know everyone else is doing it. They do know how normalized it is. They do know that they may not recognize their peers are having any sort of concern. They don't know how it affects their brain. With relationships in middle school, what can we focus on in relationships in middle school? There are people in your life who matter to you and care about you, and you try hard not to let them down. In high school, there are people in life who matter and care about you, and you try hard to make them proud. What sort of impactful information would resonate if we talk about activities? What's important to the kids? Well, I like to participate in sports. I have hobbies. I have music. All of these things can help build friendships, stay in shape, get in college. Again, these are just reflective statements to focus on what it is they say is important. Self-affirmation. You respect yourself and you want to make decisions that are best for you. Trust yourself in your choice not to use drugs and alcohol. Again, the difference in the middle and the high school response with relationship messaging. Middle school kids care very much about not disappointing people who are important to them, their parents, their coaches, their teachers. High school kids would rather focus on making people proud in their lives. Okay. So you've gone through the screening. You have somebody who has scored whatever they score, low risk, moderate risk, high risk. So here are some ways that you can respond. If somebody provides a screening to you, they score a 0. Thank you for answering the questions. That's all we're doing. Everyone gets a screen. We haven't singled you out. Thank you for answering. What do we want to do? Affirm the positive choices they're making. It's great you're choosing not to use. It's the best way you can protect your health. That's it. You move on to whatever else that they've come from. So if they have a 0 score, hey, thanks so much for participating. We appreciate cooperation. Low risk. This is somebody who's come in and they used maybe once or twice. Thank you. Thank you for being honest. Thank you for letting me know. We recommend the following information, not using because it can impact whatever it is that's important to the kid. Grades, sports, health conditions. What are your thoughts on this? If you have somebody who is scoring moderate risk, they say, hey, I use about once a month. What feedback for a child could we offer? I recommend in not using. We're going to give them the information because it can impact. What did the kid say was important? Their grades, their sports, their health condition. And then we want to assess readiness to change. What would it be like to quit or cut back? What are your thoughts? Have you ever thought about it? We get into that ambiguousness. We get into the pros and cons. What is working for you with this? What is not working for you with this? If you have somebody who scores in high risk, now we're into providing cessation advice. So this is a middle school or high school kid who is using on a weekly basis. We recommend not using. What would it be like to quit or cut back? Here are some additional resources, and we'll get into resources that are available in just a second. So you can see how we kind of amp up the responses that we have. What are your thoughts? What would it be like? I recommend not doing it. It can impact. Here are some future resources that we can provide to you. So there's a little bit of a different focus when you're doing SBIRT with adolescents than when you're doing SBIRT with adults. So this is an example, if we can get into this, this is an example of an adolescent that we are doing SBIRT with.
He completed the craft screening tool and answered yes to the relax question. The physician has completed the physical exam.
So Jacob, everything looks very normal on your physical exam. Do you have any questions for me?
No.
I see that you filled out our alcohol and drug questionnaire. Is it okay if we go through this together?
Sure.
Okay. What we talk about is confidential. I only tell your parents about what we say if you give your permission or if I become worried about a danger to you or to someone else. Does that make sense?
Yeah.
So let's take a look. So I see that you have marked that you sometimes use alcohol and that you have used alcohol to relax, feel better about yourself, or fit in. Do you mind telling me a little bit more about your alcohol use?
It's not a big deal. Sometimes with my friends, we'll drink a few beers when we're hanging out or when we're at a party. And sometimes rum and cokes.
Okay, so how many do you usually have at a time?
3 or 4 probably. I don't keep track.
Okay. And how often?
Um, Probably about once or twice a month.
Okay. So you drink with friends, sort of 3 or 4 beers or mixed drinks 1 or 2 times a month. How long have you been doing that?
Probably since last October.
So for about 6 months. I'm curious, what do you like about drinking alcohol?
What do I like about it?
Yeah.
I don't know. It's just fun to drink with my friends. Like when we're at a party at someone else's house and we're drinking with other people that we don't know. It tastes good.
Okay. So it sounds like you feel relaxed and have fun when you're drinking with friends and you like the taste. Okay. I'm also curious, are there any parts about your alcohol use that you don't like?
I don't like when I get sick in the mornings because of hangovers. And when I start throwing up, I don't like that.
Have you ever experienced a blackout, like when you've been drinking and you wake up and you don't remember what happened?
No, but that happened to someone I know though.
And have you had any problems related to your drinking alcohol, like at home or school or somewhere else?
Um, One time I missed first period at school because I had a hangover and I was late getting up. And mom got mad at me because I wouldn't get out of bed, and she said she knew I had a hangover.
Have you told your mother that you drink with your friends?
No, but I got grounded for 2 weeks after that.
So more negative things about your drinking, like getting into trouble with your mom and missing a class at school when you had a hangover.
Yeah, but I only missed school once.
Okay. I see on the questionnaire that you have not ridden in a car with someone who's been drinking and you haven't driven a car after you've been drinking. Is that correct?
Yeah.
That's great. And I hope you continue to avoid those things. As your doctor, I want you to know that I'm concerned about your drinking. When teens drink, things can go wrong, like injuring yourself. Even when you don't drink to excess, though, your brain is still developing and is very sensitive to the effects of alcohol.
Okay.
That's why I recommend that all my adolescent patients not drink at all. So if you were to think today about how ready you feel to stop drinking alcohol on a scale of 0 to 10, with 0 not being ready at all and 10 feeling very ready, what number would you pick?
Probably a 5.
A 5. So I'm curious, why didn't you pick a lower number like a 2 or a 3 that would mean you're only a little bit ready to stop drinking?
Well, I guess I'm just tired of getting in trouble.
Okay. What could you do to avoid getting into trouble?
Um, Not drink.
Have you ever tried not drinking or stopping drinking?
No, not really.
What some people your age do is try stopping drinking for a period of time just to see what that feels like.
I could probably do that.
So, how long do you think you could go without drinking?
I don't know.
Do you think you could go 2 months without drinking?
Yeah, probably.
What things would make it easier for you to not drink?
Um, I could probably do something else when my friends start drinking, like just Coke.
Anything else to make things easier for you?
I could probably hang out with some of my friends who don't drink. We're inviting them to parties and having fun because not everyone drinks at parties.
Okay. Is there anybody in your life that you can talk to about this who'll give you some support for not drinking?
Yeah, my friends who don't drink would probably be happy that I'm not drinking either. They'd support me.
Great. So you've come up with some reasons to stop drinking, like having hangovers and throwing up and getting into trouble. And you've developed some strategies to try to not drink, like spending more time with friends who don't drink or having non-alcoholic drinks when people around you are drinking alcohol. I think that's a great plan. I'm really proud of you for giving this a try. How about if I have you make an appointment for 2 months from now, and then I'll see you back and we can see how things are going.
Okay.
This is an adolescent version of the SBIRT. There are a few differences. The big thing, as we noted with adolescents, who's going to know? Am I going to get in trouble? Will my parents find out? So off the bat, she reviews confidentiality. Unless you have given me permission or there's a danger, and we all know what being a mandated reporter is, right? There is something that your parents need to know, or you've given me permission, this is going to stay here. Again, it's very non-judgmental. Kids are used to adults saying, what a stupid choice, you need to quit now, that is awful. This is not how this doctor comes across. She wants more information. Do you mind telling me a little bit more about what's going on? I notice here this number. Let's talk about it. Let's have a little chat. She asks for details. How many do you drink? How often? How long? Again, we're not saying it's bad. We're not saying it's good. Just tell me a little bit more about it, getting some more details. And then the question that surprised him the most, right? What do you like about it? I did substance abuse counseling for quite some time with adolescents, and they were always thrown when somebody said, hey, tell me what you like about it. What's the good stuff about it? They're used to people telling them, this is bad, this is horrible, don't you know how harmful this is? But what do we know? People use substances because they meet a need. With him, it was specific to hanging out with his peers. He was surprised at the question. Oh, this person really wants to know what I'm thinking. They want to know why I'm doing what I'm doing. And so he said, what does he like about it? Secondary to that question, well, what do you not like? Are there any problems? But allowing him that opportunity for us to recognize, hey, we know that you do this for a reason. We know this is meeting some need. We know that you're not drinking purposefully to feel hungover the next day. There's something in the middle. There's something that you're getting out of this. Have you told your mom? We're not saying we're going to rush out and tell your mom. Have you told your mom? And then some summarizing questions. Summarizing what he said. You like this, but you haven't told your mom. Reviewing somebody's good choices. So if somebody has said that they're making good choices, we want to very specifically point that out, pointing out their strengths, pointing out that even having this conversation is a really good choice. Expressing concern, okay? So when teens drink, here are some things that can happen. She didn't say, this is what's going to happen to you. She didn't say, see what happens when you drink a lot, you're getting hungover. It was a very generic, basic question. When teens drink, here are some things that can happen. And she did a scaling question, a readiness scaling question. And he scored himself relatively high. So again, she explored that. Why not a lower number? A lower number. What could you do? Have you ever tried? So again, we're just getting some information. We want to know on a readiness scale how willing they are, how confident they are that they'd even be willing to make a change. So she offers ideas. What some people your age do, not you need to do this, not here's the plan. What some people your age do is they stop using. What do you think about that? He seemed okay with it. So then there was the challenge question. So how long do you think you could go without drinking? When we have people who are making changes, we want to, again, go over that menu of options so that they can start to explore what is going to make this change easier. Maybe spending time with different friends. Again, we know when you change your people, places, and things, that can have a significant impact on your use. But when you have an adolescent, that may not be something they've thought of. If I spend time with different people who do different things, maybe I will then be more inclined to do different things. Explore that for a little bit. What else could you possibly do? And then with anybody, but specific to children and adolescents, we want to hit that support button. Who could you talk to about this? Who could provide support? Who do you have in your life that are making the choices that you would like to make that you could maybe spend some time with? And then she summarized. This is great. She gave him a lot of accolades, a lot of affirmations. It's really wonderful that you've come in, that you've talked to me, that you've been honest. And she summarized the whole conversation. The reasons you were thinking of quitting, you got in trouble with your mom, you got grounded for 2 weeks, you had hangover. Here are some strategies that you've come up with. Here's a great plan. How do we come back to review? So it really was a pretty easy conversation. At no point in time did he feel like he was judged, that she was telling him he was a bad kid or a horrible kid, or that mom was going to find out, or that he was going to get in more trouble. Thanks for sharing. Here's some information you may want to consider that you might not have known. Here are some strategies. How ready are you? Do you feel up for the challenge? Let's do some scaling questions. Most of the ideas he came up with were his own ideas, his own change talk that she elicited from him and then kind of built upon. It wasn't her shaking her finger in his face saying, you need to do this, you're a bad kid. It was him considering, some days I feel this way, some days I feel that way. Yep, that's pretty normal. Some kids who drink also feel the same way, and here's some things that helped. What do you think about that? So it's a very non-forceful way of having these conversations with people. When it comes to referring people out, so if we are to the point where we've had these conversations, we've gone through, we have offered some options, we have done some consideration, we have done some follow-up, but we do realize that there are certain high-risk individuals who may need more beyond that. The biggest takeaway is that many options exist. One size does not fit all. The relationships are really what we're looking to develop with this person. So, do you know, as a provider, what the criteria are to identify high-risk individuals who may need specialized care? Do you have protocol and procedures to link clients to those programs? Because if nothing up until this point is going to be successful, if they haven't agreed to things they don't want to change, or you have somebody who has a significant issue who needs additional treatment now, if you don't have those resources on hand, you're probably going to lose them. The come back and get resources later line isn't probably going to be that effective. So we need to be able to identify who the high-risk people are. Once you get the screens, know what scores you're looking for so that you can identify those high-risk individuals and have procedures and protocols in place with the resources so that you can immediately link clients to those programs. What kinds of questions do we need to know? What level of care is going to meet their needs? What level of care are they willing to go to? So even if somebody scores significantly high, that doesn't mean they're ready to run off to rehab. We need to know what they're willing to consider. And that's where some of those MI conversations are happening. What would you be willing to do? What would you like to change? What are some of the barriers that may be in place? You got to know what's available in your community. We could offer all sorts of choices, but if they can't easily access it, that's not going to work. What quality programs are available? Do we have information on the openings? Do we know what insurance will cover? So a lot of this is us doing some of the work on the front end to know what's available. Sending somebody off with a very high score and saying, hey, you might want to check yourself into rehab is probably not going to be the most effective way to get somebody into the next level. What's available out there? So we know that there's behavioral therapy. We've already talked about some MI stuff, cognitive behavioral therapy, motivational enhancement therapy. There are support groups. Do you know where they are? Do you know who offers support groups? Do you know where your local AA and NA meetings meet? Do you know what agencies in your area offer medication-assisted treatment? So that's usually people who come in with high levels potentially of nicotine or alcohol or opioids. If somebody wants to talk to you about a higher level of treatment, what does that look like? What is intensive outpatient treatment? Well, it's typically 6 hours a week or less. What is intensive outpatient treatment and partial hospitalization? We have a tendency in our field to throw out a lot of titles and acronyms and euphemisms and all sorts of stuff. And you say things like, an IOP program with partial hospitalization, and people panic. They don't know what that means. They don't know what you're talking about. They don't know anything. So how much information do you know about agencies that you would like to make referrals to so that you can give your clients some information? So that's typically more like 4 to 6 hours a day, typically 20 hours a week. Inpatient residential. Well, how long would I have to stay there? Well, where is it? Well, what do I need to do? Medically managed intensive inpatient treatment. What does that look like? What's the highest level of care? And of course, do you know where your AA meetings are, your NA meetings are, your Alateen meetings are? So be prepared that if there are people who are going to be screening into higher levels, they're potentially not going to know the resources that are available in your area. We are a high military community. They may have just come. They may not want to tell anybody at their job what's going on. They may be concerned that somebody at their job is going to know. We obviously want to reiterate confidentiality, but then what information and what information and places can we give to them so that they would know where to go and what to do? For youth, here are some considerations. Teens are less likely to follow through without the support of adults. You saw in the last clip, that was one of the questions the doctor asked. Who is your support system? Who is available that you could go to? Who can continuously help you with this? But if there are teens that do not have support systems, do we know places and people that we could refer them to? Especially if we're referring them to treatment that they may not agree with. So if they're being referred to something and they're like, absolutely not, I'm not going to go to, where X, Y, and Z, and they don't have any adults who are willing to recognize or able to recognize their concern or have their own information and education about what's available, they're less likely to go. You also may be dealing with teens who come in whose parents also may have some substance use concerns. And if there's no support at home, or maybe they're using at home with the support of adults in their life, what are the chances they're going to follow through? In many cases, by the time a substance use disorder has developed, parents are already aware. And a lot of times parents underestimate the problem. Everybody uses. I did it when I was a kid. Marijuana is legal now. It's just a little weed. It's just a little alcohol. So with the child's permission, we want to be able to provide education to the parents as well. And some of it is just some of these sentences that said, when teens use, here's how it can impact their choices, their brain development, their emotional regulation. A lot of parents may have also used when they were younger, and therefore they will say things like, well, I did it and I turned out fine. So we want to just be able to, again, non-judgmentally say, well, here are some things that you may want to consider. Here is how substances may affect your teen. Here are some options that you can choose. Plan together with the child, if you are talking about a long-term referral, how to include the parents. So we're going to get to a point in the referral, if they are a higher risk client, where you're going to have to include the parent. When you begin the screening, this would be information that should be included in the informed consent, because this would be one of those levels of confidentiality. I can't whisk you away to some sort of intensive program without your parents' knowledge or consent, or your guardian's knowledge of consent. It is important to know that when we have high levels of substance use treatment for adolescents, they can be really effective. 6% of youth in treatment receive it. 6% of youth. And again, a lot of these are the barriers of who the supportive adults are. Do they have insurance? Do they have someone to cover it? But a lot of it is, do they even know where to go? And a lot of people in the community have absolutely no idea about the resources for adolescents. And the reality is, the resources for adolescents for intense substance abuse are sometimes difficult to find. And we work for a CSB, and sometimes they're even difficult to find. How do we do a warm handoff? And of course, anytime that we can develop a relationship, have that empathic, non-judgmental relationship, and extend that to the person that we're handing them off, so the client, the teenager, does feel supported, does feel as though this next person coming in is going to maintain the relationship, the better. Quick SBIRT decision-making matrix. When we're looking at these things, screening results indicate no use. What would we do? Thank you for coming. Thank you for sharing. Thank you for being honest. Do we make a referral at that point? No. Screening results once or twice. Here's some information on quitting. So your interview is going to focus on cessation. It's going to focus on information on what use can do, how it can impact you. Would you make a referral to somebody depending on what they're reporting? Not necessarily. Somebody has monthly use. What do we want to focus on? We want to focus on reducing their use. We want to focus on their risky behaviors. We want to focus on what and how the substances are impacting their life. At that point, the referral from this matrix can be clinical judgment. Somebody has weekly use. At that point, your intervention can be linkage to maybe some potential behavioral health specialty treatment, and then we would make a referral for that. And again, these are going to be very, very individualized depending on how the conversation goes with the client when they come in. Okay, here are some additional resources. Implementing care for alcohol, screening and assessment tools, some NIDA education, how harm reduction fits into the SBIRT model. You've seen a lot of harm reduction here. So this is not, our goal is to make people quit. This is how to reduce the harm of your use so that you can get to the goals that you want to, especially if you have considered how substances may be impacting you. If you are in that pros and cons, if you're in that weighing out period, how do we reduce your use to decrease your risk? Just like with the person who was using heroin. That conversation didn't end with, I'm going to promise to quit. That conversation ended with, I'm going to tell my roommate that I have Narcan and I'm going to make sure I use clean needles and I'm going to follow up with the doctor. So harm reduction is literally that. How do we reduce the harm of your behavior? Here's an SBIRT toolkit for providers using SBIRT in schools. Sexual and gender minority youth. There are some studies that indicate that taking gender identification out of SBIRT entirely would be a good idea, depending on where you're giving it. Reframing adolescent substance use and prevention. Curiosity is one of your greatest tools as a mental health provider. And curiosity mixed with a non-judgmental personality is going to elicit really great conversations with your clients. So when you get to the point where you have detected readiness, here are some curiosity questions. What do you think could be the best results if you made the change, right? If you were completely successful in making the changes, how would things
How are you?
And we have, oh, I think you guys are, I think somebody is not muted, but still talking.
Okay. By the water?
Oh, okay. I can't tell who's talking.
Oh, well, yeah. Apparently not.
If y'all aren't going to ask questions, you can just mute yourselves because now everybody is listening to all the conversations.
Hmm.
They dumped a bunch of shell here.
Okay. Let me
Oh,
talk
really?
to the person
Yeah.
who
They
doing
must be doing some grading or something there.
Yeah,
They're called kids.
yeah.
or we could just learn about grading.
It looks
Okay.
like Searle.
From my perspective, I can't see them
Okay.
unless their camera is on, so Michelle might have to do a mute.
Catch you at bedtime.
I'm
Okay, right.
trying, but I cannot find the person.
catch you
If
at
you are
bedtime.
unmuted, please mute yourself.
Oh, I think it might have worked. Although now I'm curious about the gravy. Okay, can y'all see this screen?
Yes.
Oh, perfect. Okay, so again, if you were completely successful in making the changes, how would things be different? The amount of people who have never been asked these questions may or may not stun you. People have never considered how would things be different. They have found a thing that works. They're using the thing that works. It didn't occur to them there was a different thing that could work or that they could potentially look into making some changes. The substances have met their needs. Why would they need to make some changes? What if you made the changes? What could be different? And then we get into that ambivalence. Well, the things that aren't working well for me may change. Imagine you did succeed. And some of this begins to put into people's head hope that they could succeed where many of them have believed they would not have been able to. What might be some good things that can come out of that? If you believe this is just how you're living your life, you've stopped imagining what it could be like when you made some changes. So we want to be curious and we want them to start being curious. When we have somebody who has readiness, we know even by coming to us originally, they have shown they have some strengths. They have shown they had some follow-up. What can they do? So we look for some of these commitment words. We look for some of these action words. I will do this. I am prepared to do this. I have found a meeting that I'm going to go to. Now, with the people who were in the videos, they were able to follow up. You may not be able to do that. This may be somebody that you never ever see again. So what kinds of commitments would they be willing to make? How do you get them from, I'm thinking about doing this, to I'm prepared to do this, to I'm going to do this tomorrow? If you are into the point of doing a treatment plan, you want to make sure that you're involving all of these therapeutic angles as well, right? So potentially medication treatment, peer and self-help. Again, do you know where your local AA meetings are, your NA meetings, your Al-Anon? We didn't touch a lot about this, but depending on your particular agency that you're from, looking at things like diet and exercise can be a great thing to incorporate. How well are they taking care of the rest of their health considering their substance use? Is this impacting their diet? Is this impacting their exercise? How well do you know the counseling agencies that you're able to make a referral to? Making sure that we are not committing people early to actions when they have not said they're ready to commit. So developing an entire plan when we're not certain that they are actually interested or ready. And this gets us back to this scaling question. So if you have somebody who says on a scale of 1 to 10, I'm a 1 for change, we're not launching into this 10-step treatment plan in terms of how they're going to change. They haven't said they're going to change. They haven't said they even want to change. They don't want to be a part of this conversation. So really trying to assess and understand where your person is in terms of how willing they're ready to go on. Considering pharmacotherapy, but also making sure we have information on that kind of treatment. So they had talked about Narcan in the video with the adult, referring out, but making sure that you know when you refer out, especially if you're recommending certain programs, what their requirements are. So nothing is worse than saying, here's the program for you, and the client coming back and saying, they won't take me. I don't have insurance. I can't be covered. Do you know what the right level of care is? But do you know also what the right payment is? Here's a person that takes self-pay. Here's a person that takes Medicare. Here's a person that takes insurance. So again, a lot of it is us being able to have the information ahead of time. Here's a big thing, and this kind of goes back to the beginning in terms of our viewpoint. Seeing the patient as resistant or self-sabotaging instead of having a chronic disease. And some of that is just a reflection upon how you view somebody who may have a substance use disorder. Is this something that is diagnosable, or is this a personality trait? Are they not ready to change, or are they being resistant and manipulating? They just won't help themselves. So going into these kinds of meetings, using these screening tools to be able to help them, but addressing some of your biases in the very beginning as well. How am I going to have any fun ever again? This is what I do for fun. This is what my friends do for fun. This is what my volleyball team, my softball team, my sports team, my bar friends, this is what we do. You may not be you, right? You might not be you without this. It's important to you that you have to keep on drinking. Now look at the end of the sentence, no matter what the cost. So what have we done? We've reflected back what they've said. We've provided an affirmation. We've agreed, sure, I hear what you're saying. You might not be you. And this is so important to you that you are willing to continue it no matter what happens. Also important, we emphasize this bottom sentence. It is your choice. It is always, whenever we're dealing with clients, going to be their choice. Because the reality is no one can make you stop. People who come in, especially people who are not used to dealing with human services, or on the flip side, people who are involved in so many systems that they're used to everybody telling them what to do, rarely hear that. It's your choice. I can't force you. I can't make you. Let's just look at what's working and what's not working, and to reflect back. But just so I'm clear, you want to continue regardless of what the cost is, right? So it goes back to the say something that's so exaggeratory that elicits from the client, oh no, wait, time out. I didn't say that. I'm not willing to say that. Some more examples of promoting change talk. You don't want to develop liver problems. That worries you. You feel fine. You don't think you have a drinking problem. What's the difference? Chain and sustains. So that is in a very quick nutshell, quicker than I thought it was going to be with all these slides. That is SBIRT. If you don't already have in your agency the screening tools, you can pull up the ones that are on the list. They're easy, they're free. Everybody gets them. The biggest thing about screening, like I said, is everybody gets screening, so nobody feels like you're singling them out. And also that way you don't have to decide who gets it. Everybody gets it, then you can have the information from there.